Okay, so hello everyone and welcome to our today's session. We are very few, but hopefully some more people will join. If not, I'm sure that this will be very valuable meeting and exchange of experience, of knowledge, of different information. And the title of our session is EHDS in Practice, How to Build Trust, Interoperability and Value for the Patient. So this will be the leitmotif of our session. And before we start our panel discussion and before I introduce my guests to you, I would like to make a short introduction about EIT Health, the organization that I'm representing today. For those of you who are not familiar with EIT Health, some basic information about ourselves. I'm gonna try to change the... technology. Okay, so please give us a second and I will begin. You can see the discussion panel, but in fact this is not the most up-to-date version, so I will introduce our panelists in a while. Okay, so before we find the presentation, maybe I will just... We are able to talk without any illustrations and graphics. So EIT Health is an organization that is helping develop different innovations in the healthcare sector. We are collaborating with all the representatives of this ecosystem, with startups, with regulatory bodies, with big enterprises as well. We are helping different companies also gain money for what they are trying to develop and to implement. And we also offer different opportunities for different individuals whenever they are interested in, for example, broadening their knowledge. So we also have some training courses that are free of charge that are available for citizens of the European Union. So if you are interested in such activities, if you would like to learn more, you are most welcome to visit our website. And if the presentation is available, I will talk more about the organization. But right now, I would like to introduce our first speaker, Ms. Sinead O'Connor, representing School of Medicine, Trinity College Dublin. So Sinead, I hope that you are with us and you are able to share your presentation. And Sinead will be talking about EHDS as well. So just...
Thank you very much. It's giving me the message that you're sharing, so I'll try it again. Very good. Can you see that okay?
Yes, now we can see it okay. Thank you very much, Sinead, and the floor is yours.
Thank you very much. So my name is Sinead O'Connor. I work in the School of Medicine in Trinity College. My background has been primarily in the corporate world, both in pharma and also in management consulting. And I have done technology consulting focused on data over the past 20 years or so. So our work now in Trinity is to look at emerging technologies that we think will have an impact on healthcare and prepare the education for the future to enable the healthcare workforce to have the skills that they require. So I'm going to talk to you today about the European health data space. This is legislation that was passed recently in March. It has a staggered implementation, which means that different parts of the legislation will be mandatory for the members of the European Union at different stages over the coming 5 to 7 years. So the legislation is live, if you like, but the path, the different aspects of the legislation will be slowly rolled out and implemented over the years. So I'd like to start, if this works, yes. So I want to start with the potential, what it is that we believe that data, and of course data enabled by artificial intelligence, will bring us as healthcare researchers, clinicians, technologists, and entrepreneurs. So we know that we have data all across our health systems. To date, this has been mostly focused on patient records, which is the summary of all the information on individual patients, their different care pathways, and their interactions with clinicians. But of course, in parallel, we have seen an unprecedented rise in different types of data over the last number of years. Firstly, sensors. We are seeing the miniaturization of sensors and the ability to store large volumes of data on an almost continuous basis across different aspects of a patient's health. We also have advanced imaging, so very sophisticated imaging, which is now inquirable by artificial intelligence. So in some ways, imaging such as X-rays, CT scans, MRI, have been building up their data stores over a number of decades in hospitals across the world. And now we can really interrogate this data using artificial intelligence. Finally, we have the very exciting and promising area of genomics, whereby we have sequenced the human genome, and we now have an understanding of the impact of genetic factors on different diseases. So thought leaders in the space have described the digitization of the human body, whereby for the first time, it's not simply patients recounting their history and doctors and nurses capturing the results of various tests alongside their notes. We can now use sensors with the genome and with advanced imaging to really start to understand the entirety of patient movement, sound, and understand better about their diseases. And this is only one of the potential opportunities, is around the area of digital twins. So digital twins is where we have created a full digital copy, if you like, of individual organs. This shows a lot of promise in research, whereby we can start to model the impact of therapies or indeed medical devices, but also it starts to build new understanding about patient status in between visits. So we talk about the understanding of how patients are doing between the times that they visit hospitals and visit their healthcare provider. So digital twin is one very exciting opportunity within the area of health data. But what have we found when we even went to look at very basic information about health data availability across the European Union? And what we found in many countries and in most regions, there is sometimes, either because of the lack of infrastructure and investment in electronic patient records, or because of a misunderstanding of existing legislation such as the GDPR. So for these reasons, we're finding that data sharing is really constrained, to the point that even clinicians cannot access data about their own patients. They can't easily share it amongst different clinicians, and patients themselves have access to data. So this is almost a first problem that the European health data space has looked to solve, and that is to make sure that patients themselves can access their data and share their records with their clinical teams. So if we look at the overall goals of the European health data space, first and foremost, we want to empower individuals to control their own health data. And one of the first goals is to ensure that patients, no matter where they are in the European Union, can access or share their health record if it has been digitized within their own hospital or their primary care provider. There is also an important part of the legislation which is ensuring the interoperability and the security of health data. So what we have found is that many electronic patient record application companies are restricting or making it difficult to build interfaces or have interoperability. So this is now treated in the legislation, and interoperability is mandated for anything that contains elements of a health record. And finally, the third section of the legislation is around secondary use. So basically what the legislation is saying is that this data that you have organized and made accessible for individual patients, this data should be made available for secondary use. And by secondary use, we mean research, innovation, sharing health statistics, understanding epidemiology. So it is the part of the health data space that I think many entrepreneurs and researchers and indeed healthcare teams are very interested in. What they're hoping is that we can build a single market for products and entrepreneurial startup and research ideas coming out of health data, and that we can really use the power of health data to drill down on diseases. Rare diseases are a very important part because rare diseases are typically challenged with the small number of patients. So the European health data space will make it easier for researchers to compile data across the member states so that we can understand better the diseases which affect smaller populations. And overall, it's to ensure that we have shareability and standardization of data across the European Union so that we can mutually help and support each other as we move towards innovation in the future. So I'll make a very small comment about the difference between primary use and secondary use. It depends on the language, I think. In many countries, primary care is that community doctor that people see when they're first sick. And this is just a small point to say that primary use in the context of the European health data space means that ability of a patient to have access to their records. Secondary use refers to this pooling of data across all patients, either within a hospital or, as I've described for rare diseases, something that's shared across the European Union. So many startups and many researchers had concern that their intellectual property or their idea with their artificial intelligence models for research or a startup would be impacted by this mandate of sharing data. And what we explain to people is that in the early stages, these are the 6 data types which are of most importance. So everything that is around the individual patient record, the summary, what drugs the patient are on, what are the results of laboratory tests, any medical imaging, and the discharge summary. So many of the AI and other analytics products that have been building their own unique ideas and intellectual property won't be affected, and there are lots of supports within the European health data space to help them continue with that work. So what does this mean on a country or on a region basis? There are 2 main organisations that are being set up in each member state. One is myhealth.eu. So this is the infrastructure required to share the individual patient's patient record. And secondly, we have Health Data at EU, which is a pilot for this pooling of data across member countries. So within the Polish example, you will have at least one organization within your country that is dealing with both of these. It may be that they're separate organizations, but you will have at least one for each, and you may have additional organizations at the regional level. There is a lot of funding which is becoming available for people that are helping to build some of these individual disease databases. We have ADIRA, which is integrating health data for everything to do with lung cancer. We have the European Genomic Data Infrastructure and TEP Health in Berlin, or based in Berlin, but looking at data from hospitals right across the EU and allowing researchers to build artificial intelligence models on the data. So overall, what are we trying to do with the European health data space? It's to help pool and bring together data which will give us better information on interventions for the prevention of disease, for better diagnosis and early diagnosis of disease, and treatment and understanding of patient response to treatment, such that we can have a better holistic view of patient health, and also we can more rapidly build the research clinical trials needed for new therapies, for gene therapies, and also for medical devices. So the European health data space is hoping to support all aspects of healthcare and to enable innovation and new approaches and new insights into disease and patient management across the full life cycle. So that brings me to the end of my presentation. If anybody has a question.
Thank you very much, Sinead, for this insightful presentation, and I think that you touched most important aspects of this regulation. So I don't know if any of you would like to ask a question. Not really. So everything was perfectly clear, Sinead. Thank you so much, and please stay with us because you will join our discussion in a minute, hopefully. And right now I would like to invite to our stage our panelists. So I will begin with Magdalena Kogut-Czarkowska, a legal advisor representing Timelex and Ghent University. Am I right? Yes, Ghent University. Welcome, Magda. It's a pleasure to have you here. Yes. I would like to invite Roman Radomski, who is president of HL7 Poland. Welcome, Roman. And last but not least, Michał Jeska, Medical Innovation Institute Chief Growth Officer, if I remember correctly. Okay. Thank you so much for joining us. Okay, so Sinead, hopefully you can hear us, okay? Okay, great. I can see you on one of our screens, so your presentation was very interesting. We've been talking about the EHDS for some time in Poland already, and we ask ourselves lots of questions because what you presented is really complex, I would say. We all talk about data, but in fact, when it comes down to details, we find out that it's more complicated because we have different aspects of our data, medical data especially. So you could all hear what EHDS is about. Sinead talked about primary use and secondary use of data. By the way, we don't have this linguistic problem in Poland because primary care is called differently. But still, I think that patients are wondering what kind of data will be made available and to whom. We are also observing such a phenomenon that some patients are scared that their data will be revealed, so to say, or used in illegal way, so to say. So Magda, if I can start with you, if you could somehow translate what we've been talking about today and what is exactly written in the regulation into more comprehensible language so that everyone who is not a legal advisor or who's not an expert on legal aspects could understand as a patient what kind of data will be made available, and is it really obligatory for example, myself to let other people use my medical data?
Thank you for the invitation and thank you for the question. Maybe I can start with saying that to me the name of European Health Data Space is a bit misleading because it suggests that there's like a large database, data pool to which our data as patients will be uploaded and somebody will be able to access it. That's not at all the case. So building on what Sinead was saying, there are two aspects of EHDS that are important for the patients. First one is primary use of data, which is about using their data to treat patients, right? When you're ill, you go to the hospital, then your data needs to be used for this primary purpose. And here, the European Health Data Space builds on what already has been granted to us as under GDPR, so RODO in Poland. Under GDPR, we have certain rights. For example, we can go to the hospital and access our data, so we can ask for our medical records and physically take that paperwork or whatever file they give us and transfer it to another hospital or another doctor, for example. But that is often not enough. So if there's, for example, an accident or you're in one hospital, suddenly you need treatment, but all your records are in another hospital, this is what EHDS will help with. So it will help with immediate access and the right of to request that your data is transferred to another healthcare provider. So that is not, that is really in the interest of the patient to make sure that the hospitals have IT systems that can communicate with each other to enable them to do this. Secondary data use for, that is something, that's the second pillar of EHDS, and this is very much different because here we are talking about reuse of health data for different purposes. So it's not about treating patients, it's not about providing healthcare, it's about, well, first of all, policymakers being able to access different health data that is siloed in hospitals, in research centers, in pharmaceutical companies. So, for instance, when we had the COVID outbreak, it was very difficult for the policymakers, for regulators, to actually get their hands on the data to help stop and manage the epidemic. So, based on the lessons learned from that outbreak, this right for policy makers, for regulators to be able to access that data under specific circumstances has been sewn into EHDS. But EHDS also provides a right for the researchers, the research community, innovators to be able to access health data. That's something that we've been in Europe, especially been struggling for years because well, due to very complex legislation, and GDPR is probably the one that comes to mind when you think about barriers in sharing data. Due to privacy considerations, it was not easy. It is not easy for for a hospital to contribute their data to a scientific project. Even more so if this project has at the end, for example, a pharmaceutical company that would like to develop new products and, well, at the end make money off of it. So EHDS provides a framework for these pharmaceutical companies or for researchers or for regulators to be able to, first of all, find out what data is available, because that data is very much in various locations, so there needs to be a catalog of that data. And then there will be a streamlined process of accessing that data in general through new regulators that will be called health data access bodies. So that's very briefly, and you asked also about consent, and
yes,
we can
yes,
maybe, I don't want to sort of monopolize the floor, so I will just say briefly that in general it's not based on consent of the patients, but the patients will have the right to opt out.
Okay, so I presume we can say that the EHDS is somehow going to make the whole process more transparent, because as you said in the beginning of your of what you started to talk about, we already have different data that is accessible by different professionals and so on, and also in cross-border context. So I also perceive EHDS as a tool to make it more transparent and maybe to make it more, yes, I don't know, how shall I say that, so that patients are not worried that...
more secure, because
more
there are
secure,
security measures sewn within this process.
Okay, thank you very much. If any of you, I'm talking to my gentleman right now, would like to jump into the discussion, just feel free to do it. I would like to talk about a very important aspect of EHDS, and it was mentioned both in Sinead's presentation, and also I think, Magda, you mentioned it as well, namely interoperability, because we all talk about exchanging data, and sometimes I have an impression that we think that it's so easy, that we have data, we can just access it, we can use it for different purposes under different circumstances, of course. But in Poland, I think that we've been talking about interoperability for a long time, and when it comes into practical situation, we can see even on our country level how difficult it is to achieve this interoperability. So I'm wondering what steps should be taken to make it doable, so to say, on the level of the whole European Union. And I'm looking at you, Roman, you know why.
Okay, yes.
So please, if you could share your thoughts and ideas how we can make this process smooth.
Yes, interoperability is, I mean, someone said some time ago that interoperability is invisible. So if there is lack of interoperability, you cannot exchange data smoothly, safely between different systems, between different organizations. You cannot share this data to patients, so to medical professionals from different medical provider. So then so lack of interoperability is very much visible, but when you have everything done properly and all those systems are created, developed in that way that you can say that they are interoperable, then you can't see the problem. And I believe that sometimes with discussion of on EHDS, we can't see the problem, we can't see the interoperability, because we can easily say that everyone will have access to any data from different parts of Europe. And it's not really easy. Probably it's not even possible to get such scale of the common health data space. We will see, of course. But what are those obstacles, those difficulties? Of course, there are technical difficulties. That's pretty obvious for all of us. There are challenges mainly related not to the type of these challenges from technical point of view, but challenges related to the scale of the implementation. To implement EHDS fully probably means that all of the systems dealing with clinical data in Europe should be modified in some way. Not totally. They definitely they are not. They don't need to be replaced by other systems. But any system, every single system should be modified in some way, and that's the scale is one of the problems. But the real difficulty, real obstacle lies in the complexity of the combined aspects of implementation of common data space in Europe. It means that all the people talking about EHDS, they should be not just the technical people, not clinical people, lawyers and so on. It should be done together. And in healthcare IT, in health IT, it was always a problem because it's not easy to talk about very advanced solutions between different competencies. And this is probably the biggest challenge, at least for now. Another thing is, I believe that EHDS has very ambitious goals, but it's not an attempt to build a common healthcare system for all Europe. All national, or in some cases regional, healthcare systems will be probably modified in some way, but they will stay more or less the same way as it is now. And what we are talking about, EHDS is about common data space, the mechanisms of exchanging data between different systems, which is a quite critical challenge. And also it is about developing smaller data spaces for each healthcare systems, nationally, regionally, and so on. It's not done yet. It's not true that in Poland, even if we have clinical documents in electronic form, implemented in HL7 CDA standards, which is a very good choice for that solution. Even that, there is no common exchange of clinical documents in Poland. There are tools for that, but it's not yet common in practice. We will have many problems related to combining European requirements with our existing national requirements. They do not disappear after implementation of EHDS. They will be still valid for Polish players, and that's probably the biggest challenge. It's one more sentence, and I believe that some people think that EHDS is only about cross-border exchange of clinical data. It's not true. EHDS formulates pretty clearly, specifically, that all of the systems, EHR systems, being used in hospitals, being used in laboratories, in different medical providers, they should be interoperable that way that they can exchange data with other systems. And it's not just about creation of national contact points, as it is called in EHDS, just to have the cross-border exchange. It's something more bigger and more difficult.
Okay, thank you very much. I think that you have a great overview of the situation because you are also working on the European level, so you are witnessing somehow what's going on in the field of development of the standards, and this is indeed very challenging and very difficult. So now I'd like to ask you, Michał, what is your opinion on this barrier? Do you think that interoperability, which is a difficult word to pronounce, is also a difficult concept to implement?
Yeah, I believe it is, and many barriers already were mentioned, the technological barriers, the fragmentation of data. We're living in Poland, and I have already been in 5 or 6 different HRSs, and I cannot combine them together. There's no way for me to do it today. So how come HIS can do this in future? That would be great. It would be great to have some. It would be great to have all my daughter's data records in one place, to do it, to basically just check what happened 3 years ago, because I don't remember what she was taking as for a medicine, but I can't do this today. However, in the whole concept of our discussion, the most important information perspective for me as a growth officer is the incentives. What do doctors, what do clinicians, what do hospitals get for sharing the data? And why would they change the way they are creating and manipulating the data right now? That, I think this is a question still not answered by now. There's no incentive, like for example, you share your data, so you'll get this and this, or you share the data and you will get tax offs or anything like this. It would be great to have such incentives just to create a reasoning behind people really contributing to HIS idea, because the idea is great. It's great to have such a space. It's great to have a source of data that is true data, that we can share it, to use it, to make our researchers easier, to make our development of AI in Europe easier than in Asia or in US. However, this is still a great idea, but there is a long way ahead of us to really create openness and create a space that we can all use to make our products better in future. And just building on that, there's one more element about the fragmentation that we are in right now. In Poland is one case, but for example, I was just in Germany, and they have 16 different states, and those states operate differently about the data, and they have their own issues about how to combine their own data in Germany, and how imagining only taking the data from them is super complicated. And let's give an example. We go down with Bavaria. Bavaria will work great, and they will share the data. And also Mazowieckie will share the data. And also Catalonia will share the data. But then we have data just from 3 very typical specific regions. And can we talk about having a general data then? It can be used in the research, or maybe there's like a stamp of flawed in it. And we have to be open that HDS in 5 years won't be the tool to use to create a great AI, but in 10 years will be like a standard. And I think maybe that's a concept in the end that we should think about, that it's a long way ahead of us, and putting the milestones in the right manner, in the right historical order or future order, will be the way to go. Sorry if I took too long.
No, that's fine. I'm listening carefully because what you are all saying is very interesting, and you are presenting different points of view. So it's really valuable. And now, if I may, I would, or if anyone would like to go ahead, Roman.
If I may add something to that. Yes, I mean the problem. It's not just the Polish problem. We always talk about problems in Poland with lack of many things. The problem is across Europe, and I'm pretty sure that Poland is pretty much advanced in e-health. We are definitely above the average of European Union states, member states. So the problem, but it's not really the only problem. The problem is that we have those 27 or 28, I don't remember now, what's the current number of the states. Those 27, let's say 27 problems, separate problems to be solved. It's not like someone in very advanced European project will solve the problems of all member states. Those member states should solve the problems by themselves with help of European institutions and European projects.
Listening to you, I'm just wondering if the fears of patients are not justified if we have such challenges, so many challenges in the field of interoperability. So I would like to go back to you, Sinead, if I may, asking you about your thoughts regarding any ethical and legal challenges related to the secondary use of data. Because we are all patients, as I keep on saying. And of course, I think it's easier to explain to anyone that primary use of data is beneficial for all of us. We travel, we change places, and so on. But when it comes down to secondary use, what would you advise and how would you persuade patients? And do you foresee any legal or ethical challenges in this respect?
So it's a really great question, and when we did, supported by EIT Health, we did round tables across a number of member states, and as part of the Ireland-UK round table, we interviewed patients, patient organisations and patient research organisations. So I was expecting, I suppose, somewhat of my fears that data will be used inappropriately, and what does it actually mean? What we found from patients was an extraordinary generosity about using their data to help solve research questions for other patients. So most patients explained that if this data could be used for research and for innovation that would help other people with the disease, they're very supportive of that. And some of them actually mentioned cases where in the past they had wished that this would happen, and because of misunderstanding about transparency, it wasn't possible. So I think patients see the value of this, and they understand that for their primary use, they may have an opt-out, and then for secondary use that there will be a lot of safeguarding which is done. So I think that's something that's quite positive to take away from the patient side. On my own personal experiences of using health data, and especially in the area of artificial intelligence, where you are naturally not looking at 15 records or 20 records, you're looking at many millions of records. What I say to researchers and innovators is to try and explore de-identifying the data. So if you're doing a small research trial, yes, you want to understand exactly what's happening with each individual patient. If you're trying to build an AI model on hip fractures from x-rays, you don't need any patient identifiable data as part of that. So one of the things that we have recommended to researchers and to startups that are looking at using data for secondary use to build products which are AI or analytics enabled is to really take a look at whether you need anything about the patient that can identify them, and to separate that data completely and run and train your AI models on completely anonymous data. And in that way, it falls outside of GDPR and it falls outside of the European health data space. And I think for many of the innovative uses that we're seeing, that is quite a practical solution for those use cases. And I understand if you're running multi-country clinical trials on therapies, you will need to hold the details of the patients. So first message is patients are very positive about finding out better solutions for diseases for everybody else that has the same condition as them. And second, we're used to taking the full file, but actually we need to reorientate our approach to see which is actually needed and which we can draw to make completely anonymous databases.
Thank you very much, Sinead. So I think that it's also about, it's a lot about communication. To explain, I'm talking about patients right now, to explain to them what the process looks like. Of course, when it looks according to the rules and legal requirements, because we had, as an EIT Health, we organized a meeting in June when we invited, among others, representatives from one of the associations gathering patients or taking care of patients' rights. And we found out that the group of patients that are aware of what's going on and what EHDS is about is really small. So I think that we need to communicate, yes, as we mentioned it earlier, advantages and benefits of EHDS in the context of both primary and secondary use. So in my opinion, it's very important. I don't know if you would like to add anything. Yes, go ahead, Magda.
Yes, I completely agree that communication with patients is a key, is key because, as I said, it's not, well, in theory, the patients do not have to consent. They can opt out. But that is really a double-edged sword because in Poland, we have seen a very recent example with, opt-out of health education in school. And that seemingly uncontroversial, teaching kids about health has been spun out of control, right? And right now we have, this has been weaponized by some groups to discourage people from signing up to this education. And I am afraid that a similar thing might happen with secondary use or primary use. But I'm a privacy lawyer by training, so I've been working for years on privacy. So I'm certainly triggered by all kinds of, security concerns. I'm the one that opts out of unnecessary cookies and reads the privacy policies and doesn't ever consent to use of my data for marketing. But when I see the safeguards that are provided in the EHDS, I mean, we didn't go through them all, but for example, for secondary use, you as a researcher, for instance, you will need to apply to a health data access body, to a regulator, justify what kind of data you need. That data will be provided to you always in the identified form, so either anonymous or at least pseudonymous, and it will be provided in a secure processing environment, so within infrastructure that will not allow you to actually download the data. So it's going to be very closely monitored process, and in terms of privacy, I am not that concerned. Of course, what Roman was saying about the technical aspects that I cannot, comment on whether that's feasible or not. There are a lot of groups and initiatives working on various aspects of standardization of this process. From requirements of secure processing environments to the formats in which the access application will be submitted. But what I am afraid of is the potential for miscommunication to patients about this. And unfortunately, I would say the way that our social media distort some messages. And that's a bit of a maybe non-legal but a societal concern.
Yeah, definitely. And sorry for this digression, but I think that this was the main reason why health education in Poland failed, because of misinformation. So, but this is another topic, not for for another conference. Okay, so we already had patient's perspective, and I would like to go back to you, Michał, because you said that We also need to think about how to persuade, for example, doctors. I've been working mainly with nurses and pharmacists, so they will be somehow involved as well because they also enter different medical data into computer systems, for example. But what about doctors? So this is one part of my question. And another one is about startups. So IT companies, so to say. Do you think that we can expect like more and more companies being interested in using medical data? I'm talking about secondary use of data and building up some IT solutions. But let's start with doctors, because doctors always have their own point of view. This is my experience. And how do you think we could persuade them to be more and more engaged in the whole process?
If you make it easy for them to share the data, they will do it. And I think that's the easiest answer over here. Like, they're open to share the data of a patient if it's anonymized and it's legally acceptable for the whole legal team behind hospital or clinical center. And in the end, for them, it's just make it as easy as possible. Don't make me do anything from the perspective of a doctor or a physician. Just let it be. Let it be in a background somewhere done by the computers. And I'll just focus on my job. And if sharing the data will help me also, so it will give me some answers or help me to verify some hypothesis I have about my patient, that's great. I think the perspective of physicians is very open. However, they're afraid from the legal consequences of sharing the data of the patient. But if the legal teams say, okay, if the directors say, okay, then let's do it. I think we shouldn't be worried about the physicians. We should be more worried about who will use the data. And that's the second part, so the startups and the companies. Right now, we have in Poland and in different countries in Europe, companies built on a business model that they don't share data. Like, we will take the data from the hospital, and this is our business to sell it. So for them, this is a bad business if European Union is now sharing their European data around, because you're killing the market, really. But from startups, people who try to discover something new, so researchers at universities, having an access to verified medical data for hundreds of thousands of patients is goldmine. And we have to speak about like this. This is like really bringing something that everybody is looking for. I work with startups every day, and the main question is, Michael, how we can get the data? With whom should we speak to get the data about patients? Because most of the solutions created right now are based on data. Data that are created by physicians, data that are just videos, photos for different surgeries or just diagnostics, or data about created after, for example, blood tests. And accessing this data, it's a gold mine. Everybody would love to use it. However, for sure, there will be a group of companies saying, we don't want to share the data. This is our own gold mine. Go away somewhere else. But in the end, I think everybody's waiting for such possibility. And I mentioned it once. I will mention it second time. Last week in Germany, in Berlin, we were speaking about sharing the data. The Germans are afraid of sharing the data with the government. They have their own history around it. And now there's a shift. And now people will share the data. And everyone is now refreshing every 24 hours the page of I don't remember this German name of a institute that's there to share the data, because everyone is waiting. And is waiting on what kind of data they can get and who can get it. Because the question is, can I get the data? Like physical, like Michał, Jeska can go and get the data of hundreds of thousands of patients? I shouldn't have. Like, if I'm, for example, a researcher working for a lab, I should, but maybe not to all. And then a company, young company, let's say I have 2 weeks. I'm registered. I'm an AI created for doctors. Should I have an access to all data, or maybe just parts? And I think that's a question on what kind of data we will deliver to those startups, and how, in what format, and in how many consents there are needed. For example, do we need to ask a director or a physician, there's a startup who would like your data. Would you like to share? Or maybe there's a general saying, yeah, we can use all the data and be happy about it. So there are a lot of questions, but for sure there are many people waiting for those data.
Okay, thank you very much, Roman. I think that I won't reveal any secrets, but you are a doctor by education, so what is your perspective? Because I'm curious about it.
I am barely used medical doctor, and I didn't practice for 30 years, I guess. Well, I mean, we work in Health IT. We work closely with both technical people and clinical people. So we know the problems. We quite often we represent the clinical part of some project to those really technical people. I mean, this much more technical people than myself, and we all live with such problems for years. Now the problem is quite different scale of this. There is much easier to solve such things on the single project or on the single solution, a single application being used. When we are talking about something what is somewhere in the clouds, I'm not talking about technical clouds, somewhere in the clouds, it's much more difficult to imagine what we are talking about. And I absolutely agree with Michał that this is the key thing, that this medical professional should understand what is going on with the data he's entering into the system. And this is really difficult question to answer. And the question, this answer is more and more difficult with every day and with every month, every year of what's going on now. I think startups, because we were talking about startups for now, I think startups are our hope for the future. I mean, they are much more flexible, much faster, much more eager to take risks. And if EHDS succeeds with the sharing more data for startups, it's enough to support EHDS idea, because this is our future. This is what we want to achieve in very wide perspective, in long terms, I guess.
Okay, thank you very much. We are running out of time right now, so I would like to ask you one final question. The same question to all of you. As you're representing different fields of the healthcare sector or areas of the healthcare sector. So, and before we started our panel discussion, we spoke about the timeline. So 2029, if I'm not mistaken. So the final date to implement EHDS. So my question is, taking into consideration your perspective and your experience, what recommendations would you give to policymakers, what we are still missing, and how we can improve the whole process? So 1 or 2 sentences maximum. Michał, I will start with you.
Okay. Don't overcomplicate, and that will be enough from my perspective. Just make it simple, and that's key over here.
Okay, great. Thank you, Roman.
When talking to regulatory people, I mean from the government side, I often use the argument that please do not try to solve every single problem in your cabinets somewhere in your offices. Talk to the people who deal with the problems on every day in hospital, developing, implementing existing systems and solving the real problems. There is no wide enough view from any window from Ministry of Health office.
Thank you so much. Magda.
So I work for a Belgian company, and I often participate in European projects, and I must say, unfortunately, I don't see that much participation from Poland. I see health data access bodies who have already been created in Belgium, and they are already, trying to get, like Americans say, hit the ground running, right? And I think this is something that Roman also mentioned. It's not as if in 4 years there's going to be like a recipe for implementation that will be handed over to us from the European Commission. This is all works in the making. It's built on existing systems. It's going to be different in each member state. So I would encourage the policymakers to already look into this and get engaged in all these different initiatives that are running right now to make sure that the solutions that will be worked out also take into account the Polish perspective.
Okay, thank you so much. And Sinead, if I may ask you to give your recommendations and to sum up our discussion somehow.
So this is kind of coming from maybe an Ireland perspective, and Poland would be slightly different, but something I would say to policymakers is there will need to be some investment to make this happen. So we know that health systems, frontline care teams are dealing with more patients than was ever anticipated. Many hospitals have spent an awful lot of money in implementing electronic patient records, and it may feel that there are other places for the healthcare spend. What I would say is that some investment in the enablers of the European health data space will give you returns that may not be visible, within 12 months, but it will start to build your capability across Poland, both for better research, but also for more innovation. So it's kind of a call to say we need to spend a little bit of money on this in order to reap the rewards. If we watch what health systems in America are doing, we have Mayo Clinic, we have Kaiser Permanente, they have already jumped on to the financial value of this, and they're making those investments because they know that they will make returns. So for policymakers, don't see it as another sunk cost into the health system and we don't know what we're going to get back out of it. Other countries that are a little bit ahead of this, mostly in the United States, they have seen the potential of this on an economic value in addition to what we can learn about disease and about improved care pathways for patients. So it may be that a little bit more budget is required.
Thank you very much, Sinead. So I would say that what we need is communication, cooperation for better understanding the whole process. And yes, and I like what you said, Roman, that we need to, or the policymakers, they should go out of their offices. Yes, thank you very much, offices, and talk to people who deal with these problems or challenges on an everyday basis. Thank you very much for your participation. It was great to have you here. Thank you, especially big thank you to you, Sinead, that you could join us. And yes, and let's keep our fingers crossed for EHDS. Thank you so much.
Thank you.
Thanks very much, everybody.
Thank you.